Nosocomial infections are infections that are acquired in the hospital, and they affect 5 to 15% of all hospital patients. Now, in order for a nosocomial infection to occur, we have a perfect storm. We have a series of criteria that must be met in order for it to occur. Now, the textbook shows this as a Venn diagram, but I find that students understand it better if I show it to you as the disease triangle. For the disease triangle, we must have a susceptible or compromised host, a conducive environment, and a virulent pathogen in order for disease to occur. You have to have all three. If you have a compromised patient, but there is no virulent pathogen around, then you're not going to get a nosocomial or any type of infection. If the environment is non-conducive, one of the reasons why they keep the hospitals cold is to make a non-conducive environment. They try to clean up everything to make sure that there are no pathogens available for that host to come in contact with. Of course, if we have a person in the hospital, they are already a compromised individual, and therefore they have one of the three criteria in order for disease to occur. So we come back to that. The patient came in, torn cartilage, same day procedure, however they didn't come out until 10 days later. There could be several reasons. Number one, they could have caught a nosocomial infection. Number two, they could have had an opportunistic pathogen that they already had that came in when they were compromised due to the surgery. And I think if you think about it, you might be able to come up with some other reasons why it might have occurred. So here's some nosocomial infections and where they happen. So a normal nosocomial infection is a urinary tract infection. If you think about it, it makes sense. If you're in the hospital, you're not necessarily going to be getting up, going to the bathroom, or doing your normal processes. The physicality of getting up and going to go pee actually helps clear out the urinary tract and make sure you don't get an infection. Surgical site makes perfect sense. Your skin is actually intact before we cut it open, and when we cut it open, that's where we're possibly going to get an infection. Lower respiratory infection, any kind of respiratory device that's used in the hospital is going to produce or make an environment where those pathogens could be. Bacteremia coming through intravenous catheters, we're going to have to worry about those because again, it's going to be a way to get into the body quite easily. Here's an example of some of the organisms that we find in the hospital and also the percentage that's resistant to antibiotics. We've already talked about antibiotic resistance before. It's something that's very important. We have specific organisms that we tend to find in certain locations in the hospital. And again, these are healthcare associated infections. MRSA is an example of something that we're concerned about with antibiotic resistance. Methicillin-resistant Staph aureus. A piece of information that you might find interesting since we're talking about nosocomial infections. So there's actually two strains that we find in general in the population. USA 100, which is found in the health care system. If you get a nosocomial infection, if you get MRSA in the hospital, it's going to be USA 100. However, if you get an infection in the community, 89% of the community-acquired strains is the USA 300. There's actually a difference between the strains hospital-acquired and community-acquired. This is very important to understand because if you think about it, so a person goes to the hospital, they get MRSA, and then they leave. Wouldn't you think that that MRSA would then get out into the community? We'd have a higher rate of it in the community. We don't. And that has to do with the difference between the host being compromised in the healthcare system, but not in the community. So here's just a little bit of information given about MRSA. And it shows the proportion of that bacteria which is methicillin resistant. It doesn't show the incidence, so we're not talking about how many people. We're just saying how many of the bacteria that people got was actually methicillin resistant. I want you to notice that Greece and the United Kingdom have higher amounts. And then we have the Czech Republic, Netherlands, Sweden, and Norway at much lower percentages. Now the question is why would it be different between Greece and the United Kingdom and really kind of the rest of the countries listed here? If we talk about procedures in the hospital, some procedures are more likely to get an infection than others. I want you to look here. We have hemodialysis. We have 813 out of 1,807. An IV catheter, we have 1,000 out of 16. Surgery, so on. Now I want you to notice the differences. Which one of these actually has a higher infection rate? You go, okay, oh, there's tons of them here, right at this number. But if we look at this number, this many out of this is not as significant as this out of this. Emerging infectious diseases are diseases that we're finding an increase in incidence or show that possibility in the future. Here are some examples of contributing factors that could cause this change or this increase in the infectious disease. One is genetic recombination. That's where an organism or a virus actually gets genetic information from some other source and updates itself. We see that with avian influenza and E. coli 0157. We also have the evolution of new strains that we haven't seen before, that they themselves have changed. Of course, antibiotic resistant strains. The changes in weather patterns are going to determine which ones are going to travel in which direction. Modern transportation is kind of a big deal because that means that if we have an outbreak in one part of the world, then it can get transported to another location. West Nile virus, of course, via its name says it came from the West Nile. We now have it in the United States because of birds that were transported to the United States. Ecological disaster, war, more people in areas are going to help increase the numbers of infectious diseases. Animals and how we control them, whether they come into more contact with people, etc. And then also where things just went wrong, where potable water wasn't available, or just where the public health system failed. And these are examples of those cases. Now, if we talk about viruses and them updating themselves, so here we have a couple of options. We have a North American swine influenza or flu. We have an avian gene pool, and you get a North American swine, human virus, and an avian virus came together, which caused a pandemic in 2009 when we had a Eurasian swine virus also interact with that assortment. So viruses are very interesting in their aspect of being able to collect genetic information if the organism is infected by more than one virus at a time. And we've talked about this process when we talked about viruses. So epidemiology is the study of when and where diseases occur and how they are transmitted. Epidemiologists study the disease, determine the etiology of the disease, and figure out the factors of how it spreads, and they develop methods on how we might control it. The CDC, the Centers for Disease Control and Prevention, is a United States epidemiological information center, and they collect information about the morbidity and mortality of particular diseases. And you can check out their website to see information about it. Now, epidemiology has several different ways in which we look at and collect the information. So John Snow mapped the occurrence of cholera in London and noticed that people who got water from a certain location actually tended to get sick. Semmelweis showed that if you washed your hands, you decrease the incidence of puerperal fever. Florence Nightingale showed that if you had proper sanitation, then that would decrease the incidence of epidemic typhus. Now, when we look at epidemiology, it can be descriptive, where you have a collection analysis of data. The example is what Snow did. Analytical, where you analyze a disease and determine its cause. That's Nightingale. And then experimental, where you actually have experiments with controls and you determine what actually is going on based on those experiments. And that was Semmelweis. Healthcare workers are required to report specific things that go to the local, state, and national offices. There are nationally notifiable diseases that physicians are required to report. This table here is the list from 2013. If you have someone come in with any of these, you have to report it. The CDC makes the morbidity and mortality reports. Morbidity is the incidence of a specific disease, and mortality are the number of deaths from that disease. The morbidity rate is the number of people affected in relation to the total population, and mortality is the number of deaths related to the total population. So we talked about terminology, microbiota, Koch's postulates, talked about how they worked and why we would use them. Then we talked about disease incidence, talked about the disease curve, and emerging infectious diseases. Thank you very much for paying attention.